truly humbled by the honor bestowed upon me to ask me to give the fifth John Addenbrooke Lecture. And this thought has polarized more when I heard the history of John Addenbrooke and what he has done. My God, it is humbling. My topic today, as you have heard, is equity in health care delivery from theory to practice. And I'm going to talk quickly, as much as I can, on definitions, what is global health, what's equity, and I will go on to say what is theory, but what is the reality, and then go on to say who cares, who acts, who pays. Actually, these words were articulated by Jane Somerville, and a lot of you will know Jane. She's a very lively character. And I will talk about the Aswan Heart Center as a model, and again, in a humble fashion, look into the future, if I can. Now, just definitions. What's equity? I think everybody here understands, but in healthcare delivery, when everyone is offered optimal healthcare regardless of who he or she is. What about inequity, health inequities, and that is the title of my talk, and that is is dealing with preventable health conditions experienced by disadvantaged population. And my God, it is common. To what extent? Over 85 or 89% of the world population are in this group, not receiving optimal treatment. Is that acceptable? I will go on and show you why and how in some ways we can address this incredible inequality in healthcare. But I will try and concentrate, of course, on cardiovascular disease because I know most about it, or at least I think I know more about it. Now, in theory, the notion that we are all the same has been articulated repeatedly. And I just show a few examples. The first one is a lovely little book written by Jim Wotton about a child, Nikosi Johnson. As you can see, Nikosi lived 12 years. More than that, he knew that he was going to die before reaching the age of 12. Why? Because he developed HIV infection during birth. And so he was doomed. But Nikosi said, okay, I know I'm going to die, but I will make sure that my life is worthwhile. I'll do something. What did he do? He went on around the world, that's a true story, lecturing, and the title of his lectures were, "We Are All the Same." And that's the title of this book. I think I recommend it to you, beautifully written about Nikosi, how he knew that he was going to die, how kind people tried to help him, but the determination that I'm not going to give up before passing this message that we are all the same. Now, much more powerful people have articulated the same message, and only recently, during the last few weeks, months, Dame Minouche Shafik I don't know how many of you know Dame Minouche. She wrote this beautiful book entitled What We Owe Each Other. Now, just to let you know a thing about Dame Minouche, she's Egyptian. She was born in Alexandria. She served at the World Bank, dishing money to underprivileged people. Then she was the deputy governor of the Bank of England, and that's why she is Dame Minouche. And then she went on to be the vice chancellor of London School of Economics, again fighting for the poor, for the underprivileged. And the book is really lovely. It starts very simple by how young girls in Egypt, but also in South America and many other parts of the world, are underprivileged and they have no education, but they try very hard. But then the book goes on and on, telling you more about economics and theories coming, how to deal with the problem at a very high level. And she quotes the LSE, where she has been for over 8 years now. A brilliant lady. Now, if we go further, why are we all the same? It's so obvious, because the Human Genome Project has shown that our background genetics are exactly the same. All right, we can have minimal changes, people look differently and so on, but basically we are all the same. So if we go on trying again in theory, with the United Nations SDGs, Sustainable Development Goals, they're beautifully articulated about how to deal with the problem, but it's all theory. And that has resulted in the Millennium Goals, where everybody thought that that could be the answer. But as this lady on the picture had her doubts about, she asked the question, will the Millennium Development Goals hit their target? And the answer is no, they didn't. And it failed. So what comes next? All of us now are suffering from the sequelae of COVID-19. And at the time, again, the notion that COVID-19 vaccination will be equitable, and that totally failed as well. As you can see, this lady presenting for vaccination only to see out of stock. Where? In underprivileged countries. So where do we go from here? If we look at some statistics, it's really, and I said I will try and limit myself as much as possible to cardiovascular disease. It is the leading cause of death and disability. And some big figures here show that 17.9 million deaths in 1 year. That's from the WHO. And 75% of the burden of disease in low and middle income countries are due to cardiovascular disease. What happens, it hits low and middle income countries where there are more children and young people. And if you look at statistics, there is massive inequality in childhood annual mortality reflected in the childhood annual mortality. For example, in 1 year, 2013, there were 152 death of children per 1,000 as compared to 2.5 in Guinea-Bissau as compared to 2.5. That's like 70-fold. How can that be? How can that range of mortality, children mortality, be in the world? But it's a reality. We're living with it. Now comes the question with Jane Somerville, I'm quoting her, who cares? Oh, it's obvious that all of us has to care, at least in theory. We care. But then the next question, who acts? Then I tried to provide some tentative answers. I think professionals, as people who see that suffering, that too incredible inequality firsthand. We see it almost every day. I saw it in the teaching hospital in Cairo when I was a resident. I saw children dying of pulmonary edema due to a correctable lesion. In that case, it was a leakage of the aortic valve. And I just knew that there could be something, and there were starting cardiac surgery which could deal with that problem. But I just used to go at night, comfort the child, and give him any drug just for him to die, to sleep, knowing that he knew that he was going to die within a week or two. Oh, it's dreadful what's going on. Apart from professionals, what can professionals do? Actually, professionals can do a lot more than we think. And that by just getting together and forming non-governmental organizations, they should team up with good administrators who work together in harmony, who are transparent, and importantly, convince the population that we are your agents, so to speak. And because the population, after all, is the owner of the programs. They should have government support, but you cannot ask the governments to take over because they have other priorities, including that they need to be re-elected. But they have a lot of other problems. So all what you require, these NGOs, is require support. Just give us your blessings. And we don't want to money this or that or the other. And importantly, which people do not think of, is the idea of sustainability. Many people go and work for a week or two and then leave the patients all doing very well, and then only to learn that more than half of them died, and nobody is either caring for them, and this effort is just like a flash in the pan. It's just not having an effect. So whatever you do, it's got to be sustainable in the longer term. And how can that be? Many people think, oh, you need a massive amount of money. You might meet the money, but human resources are a lot more important than the money, because you need people to inspire people to carry on locally long after you leave, and then help them with the physical infrastructure, whether it is the hospital or ongoing expenses, etc. But who pays? I think, again, if there is a will, there is a way. And who pays? We all know that money is sparse and everybody is looking for resources. But can be a collaborative effort, and I'll show you an example when people believe that this is something they want. Even small contributions add up to a huge amount, which can make it sustainable, at least in the short term. I would end my talk by looking at our own experience, meager as it might be. Aswan Heart Center and the Chain of Hope first, and then the Aswan Heart Center, adopted some of the principles I talked to you about, and it had integrated service, treatment at the highest level, training and research. Now, the treatment had to be offering state-of-the-art, free of charge medical services to all patients, regardless of their color, religion, or gender, and importantly, whether they are rich or not. This is essential, and that is the basic right of people is to get equity in healthcare. And then the next thing is to try and get training generations of young people locally to take over and make sure that this effort is sustainable. And importantly is to have research as an integrated part of the service, not just anything. This is just research is a luxury. It's not. It is part of the effort to have a sustainable service to these underprivileged people. What kind of research? I will show you a bit more about that. And then I will try and focus a bit more on Aswan Heart Center. I don't know how many of you have been to Aswan, but it is a beautiful place. But people have been dreadfully underserved for generations. And when we used to go to Cairo with a team of pediatricians, surgeons, children who arrived from Aswan, arrived in a sorry state, collapsed. It's not a very far, it's like 700 miles away, but on the train all night to come. So we decided that this is untenable. We really have to have a center in Aswan itself to serve the local people, but people from around, from Upper Egypt, who do not get this type of treatment. And the Aswan Heart Center has now flourished. It is now only about 15 years old or less than that, but it performs over 1,200 open heart operations, including arterial switch operation, sometimes 2 to 3 a day in neonates. It also performs artificial heart, left ventricular assist devices, a lot of aortic surgery, and primary PCR for the population. The net result is to try and alleviate this incredible suffering. I show this picture here of, look at the expression of the child in pain, despair, but equally the father has the same type of pain. Look, and it's not this suffering and anxiety, which you can see here, is in the entire family, maybe the village. So by addressing disease of these underprivileged people, you are treating a very large number of people. So the Aswan Heart Center started by 4 or 5 people. Now it's 650. And the amount of work is escalating all the time, all free of charge. And you can see, for example, the number of operations, open heart operations, is now between 1,000, 1,200 with a dip due to COVID. Equally, the interventions are now nearly 4,000 a year, all for free for underprivileged people. We don't also discriminate against rich people, of course. If they need it, they come, but they do not have priority like the underprivileged people. And the result is that they pay for a lot of the services for the underprivileged people. And importantly, the cost of running that center alone is like $30 million or pounds a year. Where did that come from? From small donations, at least 70 to 80%, from small donations of people who really are on the borderline of poverty, but they're convinced that there's something needed here. The center also works, the young people in particular, on developing innovative operations to suit the underprivileged people, the neglected things, for example, in transposition of the great arteries with intact interventricular septum. Sorry to be a bit technical. The results of the arterial switch operation is great, but there are so many neglected people who has missed the chance to be operated on in neonatal life. So by devising this operation where we modify the conduits in the atria, we make use of the contractile part of the atrium to fill the left ventricle with markedly improved results, but also with 0% mortality at the time of operation, which transforms the life of some of these patients who have been battling for up to 25 years with a hemoglobin of 25. They're very hemoconcentrated. Their blood is like molasses. They can hardly walk. When within 24 hours, they are transformed. And we hope that that kind of operation will compete with the arterial switch operation in the longer term, because the cardiac output improves dramatically by improving the filling of not only the right, but also the left ventricle. And so another operation which is pioneered in Aswan is common arterial trunk, or truncus arteriosus, which requires very expensive surgery because you need a conduit, and that costs 2,000 to 3,000 pounds. Where do they get it from? This operation actually uses autologous tissue and without using conduits, and it makes it accessible, as well as it can be done in neonates and avoid a 93% mortality during the first year of life. So a lot can be done in these areas. In the center, the outpatient per year has increased to 225,000. Importantly, we keep an eye on the cost and cost effectiveness, including everything. And that shows that an open heart operation on a baby even costs between 7,000 and 8,000 pounds or dollars. And that is like 80 to 90% lower than in developing world, which is satisfying because you're at least making an impression on the problem in a cost-effective manner, and that gains the confidence of the people as well. Knowledge dissemination is essential, and in the Aswan Heart Center, they have different ways of doing that. Some of it is through observation, periods of observation, others workshops, and importantly, we have international conferences in a series called Global Cardiology Science and Practice, which has a specific journal which is being printed regularly from the Aswan Heart Center. Research, I mentioned earlier that it is an integrated part of the service, and it ranges from clinical, trying to identify how we can improve the results and how does it fit within what's being achieved worldwide. Life sciences, a lot of molecular biology, and tissue engineering, and that's very important because they're creating a living valve, for example, having an IPS, induced pluripotent cells library of all the patients with genetic diseases. We have to date about 40 or 50, aiming at 100 lines of IPS from the patients to experiment with personalized medicine in the near future. And importantly, population studies. The Aswan Heart Center has a satellite in a small Nubian village about 40 miles away from the center, the Balana. And the Nubian village has 28,000 people, which are being followed both phenotypically, but with all other omics, including genomics. And this is the specialized building. And the first results from that population study is being presented now as we speak, this week, in Boston by this young lady, Marina Seuss, who is studying for a PhD in population science. So this is just a quick expose of the first thing is the theory of equity in healthcare delivery is well developed. We really do know what we should do, and that in spite of that, major inequalities persist as we speak and requires urgent action. I just presented a unifying, because we need to work together, sustainable effort involving all stakeholders, that it is feasible and has been implemented on a very small scale in the Aswan Heart Center. This can be generalized in a global fashion, but we really need a concerted effort, and we need the expertise of economists. They should come up with theories of how we can continue this work without jeopardizing the principle of we are all the same. Thank you very much.